Hello everyone, I am Rishikesh Urmode from 2018 batch. I will be explaining peptic ulcer disease in unique way. Let's imagine a situation. A doctor is sitting in OPD and 45-year-old patient comes to him. Now we listen to their conversation. Doctor is saying, please have a seat. What is your problem? Patient says, doctor, please help me. I am experiencing severe pain below my heart. It feels like it's burning inside. This pain is not letting me to eat and sleep because it increases after eating and also at night. Doctor, please help me. Doctor asks, are you experiencing any nausea, vomiting and diarrhea like thing? Patient says, sometimes I experience nausea but no other issues. But this pain is since 2 weeks. Now it's getting impossible for me to tolerate. The pain sometimes radiates to my back. There is one more thing, doctor. I'm getting tired early nowadays. One should not hide anything from your doctor and police. Now you tell me, do you smoke? Come on, speak out the truth. Patient says, yes doctor. Now doctor says, after analyzing your clinical picture, I can say that you are suffering from peptic ulcer disease. We will do some more investigation to confirm the diagnosis. Oh, peptic ulcer disease. Doctor, will you please tell, how did you come with this opinion? Doctor says, patient of peptic ulcer disease experiences epigastric burning pain that tends to occur 1 to 3 hours after meal and it worse at night. Nausea, vomiting, bloating, belching and weight loss may also be associated. Patient says, yes doctor, I have lost some kgs in this period. I know something about this disease. POD occurs mostly in 5th decade of life due to increased use of NSAIDs, which is also a risk factor. People older than 60 years are also getting disease. My doctor cousin from US was saying they don't get much cases of POD there. The disease is more prevalent in developing world. Says, yes, you are correct. The disease is more prevalent in developing world, but the prevalence is also decreasing with increasing hygiene practices. H. pylori infection, cigarette smoking, COPD, alcoholism, psychological stress, certain viral infections like CMV and HSV are the risk factors. Oh, I know something about H. pylori. I have read somewhere that about 90% cases of chronic gastritis are associated with H. pylori, which is spiral or curve-shaped gram-negative bacteria. With the help of flagella, it remains motile in the viscous mucus and an enzyme called urease generates ammonia, thereby elevates local gastric pH and enhances the bacterial survival. Bacteria also has adhesin that enhances the bacterial survival. Toxin-associated gene called CAG gene is also involved in the disease progression. Doctor says, wow, you know many things about the bacteria. Patient says, thank you doctor. Now I wanted to know how does disease occurs? How does it progresses? Doctor says, peptic ulcer disease results from imbalance between mucosal defense mechanism and damaging factors that causes chronic gastritis. It develops in the background of chronic gastritis, but are more common in proximal duodenum within few centimeters of pyloric wall and involves anterior duodenal wall along lesser curvature near interface of the body and antrum. Ulcers are mostly solitary. If we look at the gross features, they are sharply punched out defects with overhanging mucosal border and smooth, clean and clear ulcer base. If we see microscopically, there are thin layers of fibrinoid debris with underlying inflammation merging into granular tissue and deep scarring. Surrounding mucosa usually exhibit chronic gastritis. Can you see this? This is how a peptic ulcer disease appears grossly and microscopically. Patient says, oh, doctor, I have understood whatever you told, but my doubt is why I am getting tired early. What is the reason behind that? Doctor says, because there might be blood loss which is leading to iron deficiency anemia. Iron deficiency anemia, hemorrhage, perforation are the common complications associated with peptic ulcer disease. Perforation is a medical emergency. So can you see this table? There are some additional complications of peptic ulcer disease are depicted. Then patient says, okay doctor, now I wanted to know how will you confirm your diagnosis? Doctor says, I can confirm your diagnosis by various tests. I can use barium studies, which is a radiographic study, or I can use endoscopic procedures. Barium study will show this kind of result, that is widely marketed crater, often seen as a bulb. This is not used as a first test for documenting ulcer, also not good in detecting smaller size lesion. Endoscopy provides most sensitive and specific approach. It is helpful in identifying lesion too small to detect by radiography. Now, these are some other tests which are used to diagnose peptic ulcer disease, which includes invasive tests which require endoscopy or biopsy, which are rapid urease test. It is a sensitive test, it is simple, but false negative with recent use of PPI, antibiotics and other medications. Histopathological staining can also be done, which is also sensitive, which requires pathological processing and staining, and it provides histological information. Culture can also be done, but it is time consuming, expensive, dependent on experiences, and allows determination of antibiotic susceptibility. Certain non-invasive techniques are serology, which is based on the antigen antibody complex formation, which can be detected by ELISA, which is inexpensive, convenient, but not useful for early follow-up. Urea breath test, which is also sensitive, as like serology, which is simple, rapid, useful in the early follow-up, but false negative results are seen with the recent therapy. Stool antigen detection can also be done, which is also sensitive, it is inexpensive and convenient. After listening to the process of diagnosis, patient asks the doctor about the treatment. Patient says, then how will you treat me? The doctor says, I will give you two types of drugs, which are acid suppressing drugs and mucosal protective drugs. Acid suppressing drug will decrease the acid secretion, that is, they will decrease the damaging agent. This includes antacids which are Mylanta, Molox, Tums and Gaviscon, which are given as 100 to 140 milliequivalent per liter, 1 and 3 hours after the meal and at bedtime. H2 receptor antagonists, which are cimetidine, famotidine and nizatidine, are also given. Ranitidine was the commonly prescribed drug in the PUD, but now it is banned in India due to risk associated with it. Proton pump inhibitors are the very effective drugs in the peptic ulcer disease, which are omeprazole, lansoprazole, pantoprazole, etc. Mucosal protective agents such as sucralfate, prostaglandin analogs like misoprostol, bismuth containing compounds like BSS, that is bismuth subsalicylate, are given to protect the mucosa. Okay doctor, thank you so much. You gave a lot of information about the disease I am having. Once again, thank you doctor. That's all. I hope you have understood the peptic ulcer disease through this doctor-patient conversation. Thank you.